Once 3 measurements are complete, the measurement data are shown on the display. MicroLife, a partner for people, for life.
Assalamu alaikum wa rahmatullahi wa barakatuhu. Good evening and welcome to another exciting episode of Doctor in the House. I'm your host, Dr. Muhammad Rahman, and it is a pleasure to have you with us again. And it feels really good to be back in this seat, especially. So, this evening we very much look forward to having our guest on, Dr. Shaun Lynch, and he's a nephrologist attached to the Eric Williams Medical Sciences Center. And we look forward to chatting with him a little bit later this evening on kidney disease and a little bit about his experiences in training and in practice as a nephrologist. So we decided to change things up a little bit, and this year, for Doctors in the House, you know I'm back after a 2-year hiatus, we're going to try to do things a little bit differently. And I noticed that we have a little bit more special effects capacity. Hats off, kudos to the special effects team. So hopefully we're not going to have any hiccups tonight. All right, and let's dive right into our first segment, Medical News, where we discuss some current medical news and trends relevant to us here in Trinidad and Tobago. So first up on the list, intermittent fasting and diet may be best. The findings from a recently published study in the January issue of Obesity suggest that when it comes to weight loss, intermittent fasting, in addition to a restricted calorie diet, may be superior to either dieting or fasting alone. In this study, a group of close to 90 middle-aged and older, overweight or obese women were randomly placed into one of 4 different groups. The most successful participants in the study lost about 0.5 to 1 kilogram per week. So in the study, after a 2-week lead-in, 88 women between the ages of 35 and 70 years of age, with a body mass index of between 25 and 42, who did not have diabetes and who were not physically active, were randomized to one of 4 groups for a total of 8 weeks. The first group had no reduced calories or fasting, and this served as the control group. That is, they received 100% of the calories necessary to maintain their baseline weight. This group comprised 12 women. The second group pursued intermittent fasting, and we're going to discuss very shortly exactly what that means, and a reduced calorie diet. A reduced calorie diet is 70, or is defined as 70% of the calories needed to maintain their baseline weight. In the third group, they pursued intermittent fasting with a normal calorie intake, that is, no reduced calories, while in the fourth group, they pursued continuous reduced calories, 70% of what is required to maintain their weight, and no fasting. In the fasting groups, participants fasted from 8 a.m. to 8 a.m., that is 24 hours a day, or for 24 hours at a time, on 3 non-consecutive weekdays, more likely Mondays, Wednesdays, and Fridays. They were allowed water and small amounts of calorie-free foods and beverages, things like black coffee or tea, diet drinks, sugar-free chewing gum or mints, and a cup of 20-calorie broth, 250 milliliters. All foods were delivered every 2 weeks, and the diets had the same nutrient composition, that is, 35% fat, 15% protein, and 50% carbohydrate. Women in the intermittent fasting reduced calorie group had greater reductions in weight, fat mass, total cholesterol, LDL cholesterol, and free fatty acids compared with women in the reduced calories alone or intermittent fasting groups. The study authors concluded that this study demonstrates intermittent fasting approaches using repeated 24-hour fasts to improve metabolic health while in energy deficit, but not when in energy balance. That is to say, if you're able to do intermittent fasting together with decreasing the amount of calories per meal or the amount of calories consumed per day, you're better off than if you did either one alone. So, moving on to our next segment, delayed newborn baths boosts breastfeeding rates. Skin-to-skin contact between the newborn and mother immediately after birth has well-known benefits and is urged as part of usual care. But the rationale for another recommendation by the World Health Organization, delayed bathing, has been less clear. Theories surround the idea that newborns recognize the scent of amniotic fluid, that fluid that surrounds the baby inside of the mother's womb, as a cue, prompting them to breastfeed, with one study indicating that newborn suckling responses were extended when exposed to their own amniotic fluid. Subhanallah. With effects to reach their breastfeeding goals failing or falling short, the study authors implemented a departmental intervention whereby nurses were encouraged to wait for 24 hours before bathing newborn babies, or at the very least a minimum of 12 hours. Prior to this intervention, at the hospital in question, the initial bath was completed within 2 hours of birth. To evaluate the program's effects, or the effect of the intervention, the authors compared data on 448 mother-newborn couples in hospital prior to the intervention with 548 mother-baby couples post-intervention, or after the intervention was made to delay the time at which the baby was bathed. There were no significant differences at baseline between the mothers and newborns in either group before and after the intervention. And this is good practice in clinical trials. With a shift in the median time from birth to the first bath, moving from 1.9 hours to 17.9 hours post-intervention, the rates of in-hospital exclusive breastfeeding, that is without any formula, increased from 59% to 68%. That was statistically significant. The odds of the mother's intent to use human milk exclusively at discharge from the hospital, meanwhile, increased by 35% post-intervention. The benefits of delaying newborn bathing on breastfeeding rates were most apparent among those who gave birth vaginally. Delayed bathing also led to a greater likelihood of normal temperature among newborns, building on prior work that had demonstrated this. So, delaying newborn baths definitely seems to be the way to go. But if my daughter is still up looking at this, still no evidence for any benefit in older children. So that brings us to the end of our first segment. I hope you guys enjoyed it, and we're going to take a break, go to some commercials, and we'll be back afterwards with our second segment. Stay tuned.
High blood pressure is as dangerous as an overpumped balloon. Measuring your blood pressure every day can save you from risk of high blood pressure. MicroLife fully automatic upper arm blood pressure monitor with stroke risk detection. MicroLife AFib screens for atrial fibrillation while taking your blood pressure. High blood pressure and atrial fibrillation are both considered controllable risk factors for stroke. If AFib is present during blood pressure measurement, the AFib icon is displayed flashing at the end of the triple measurement. Once 3 measurements are complete, the measurement data are shown on the display. MicroLife, a partner for people, for life.
assistance? Come check us out at Ultimate Medical Clinic. We offer a wide variety of medical treatments. Why live in pain and suffer with wounds and ulcers?
Ultimate Medical Clinic also provides laser therapy for pain relief and wound healing.
We also treat arthritis, knee, neck pains, diabetic neuropathy, diabetic foot sores, psoriasis, eczema, and many more health conditions. Call us today to schedule your appointment, 665-1188, or visit us at 111A John Street, Montrose, Chaguanas.
Get great unbeatable prices from Extra Foods. Minced chicken per pound, $19.95. Fine choice chicken breast, $15.95 per pack. Perdix chicken nuggets, 300 gram, $19.95. Happy oil, 1.5 liters, $17.50. Oasis water per case, 5 for $95. Ibis flour, 2 kilogram, $11. Happy macaroni, 800 gram, $7.95. Fruta, 1 liter, $8.50. Add Kellogg's Unicorn cereal, 19 ounce, $29.95. Only at Extra Foods, Endeavor, Grand Bazaar, Arima, and Chaguanas Main Road. Extra Foods, always something extra for you.
Welcome back, folks, and now we're on to our second segment entitled Posts in Perspective. And here we're going to be looking at a hodgepodge of posts from social media that are trending and hopefully relevant. So the first topic, good old ghee. So this is courtesy of the Cleveland Clinic Health Essentials. Ghee, also known as clarified butter, has been used for thousands of years as the preferred cooking oil and even in Ayurvedic practice as a therapeutic agent. Although it is very expensive these days, no one can deny its delicious appeal. Over the last several decades, ghee, or clarified butter, has been implicated in the increased prevalence of heart disease, specifically coronary artery disease in Asian Indians, due to its content of saturated fatty acids and cholesterol, and in heated ghee, cholesterol oxidation products, which could potentially accelerate atherosclerosis, or hardening of the arteries, increasing the risk of heart attacks, strokes, peripheral vascular disease, and more. Now, as usual, we're not quite sure as to the magnitude of effect, either good or bad in practice, because these questions have not been specifically addressed in large human clinical trials. Most studies that have been published were either of animals or small groups of people, and it's very difficult to apply these results to everyone unless they've been assessed in much larger groups. But on the positive side, as we can see in this meme, and especially as related to the gut health, they note that it is, in fact, lactose-free, which is particularly helpful if you are lactose intolerant. It contains butyric acid, which helps to maintain the intestinal barrier and health. This is especially relevant in current thoughts of how some diseases are caused. Specifically, inflammatory bowel disease comes to mind, and even colon cancer. So, in moderation, and probably around 10% of your total daily energy intake, ghee or clarified butter may be worth the spread on toast or on Facebook. And we're just going to leave my thoughts on rasgulla and gulab jamun out of this conversation for now. So, as newsworthy, this post gets the Doctor in the House seal of approval. And now we move on to the second topic, natural bypass. So this little gem comes to us courtesy the Daily Health Gem. And in this graphic, and I'm sorry it doesn't show up quite so well, the size of it is difficult, they say, no need for angioplasty or bypass. Natural therapy for opening the veins of the heart. Lemon juice, ginger juice, garlic juice, apple vinegar. Mix all of the above, boil in a light flame, and when it becomes 3 cups, take it off and cool it. Now mix it with 3 cups of natural honey and keep it in a clean bottle. How to take? Take 1 tablespoonful of this juice daily before breakfast. Your blockage from veins will disappear slowly. Share with your family and friends. So although comprising mostly safe constituents and not likely to be harmful, there is absolutely not an iota of evidence for this helping to clear coronary arteries, or indeed any arteries in the body. What's most distressing to me is the sheer number of similar posts that I've seen over the years, even from family members. Now, I'm not knocking the idea that there may be benefits to some herbal preparations. In fact, science has proven, and large clinical trials have proven, that definitely there are in some cases. But Coronary artery disease is an extremely common disease which occurs as a result of years of plaque buildup inside of the arteries that supply the heart. And that's a pretty irreversible thing in terms of medications, even very strong medications that we use. In fact, there's a group of medications called statins that have been shown to decrease the size of the plaque inside of the vessels around the heart, and it really does so in a very, very slow fashion. It works more in stabilizing the plaque and stopping it from breaking off and causing difficulties later. So when it comes to this lemon, ginger, garlic, and apple vinegar remedy, I'm going to go out on a limb here and say that even in the absence of formal clinical trials assessing the efficacy of these, there's probably very little chance that these will effectively unblock anybody's clogged arteries, especially if somebody is going to be encouraged by a graphic like this to not take their doctor's advice and get assessment for a stent placement or a bypass procedure. But if you want to mix up a refreshing beverage, and this certainly sounds very refreshing, then by all means go ahead. And because of false and unbacked claims, we are going to label this fake news. Next, nuts for mental health. And this comes to us courtesy home remedies and natural cures. The cashew tree, and let's see the graphic, there we are. And this graphic claims natural antidepressant, 2 handfuls of cashews is the therapeutic equivalent of a prescription dose of Prozac. Okay, so the cashew tree, or Anacardium occidentale, is a tree native to tropical America. Though despite that, it's widely cultivated in India and East Africa, India being its largest producer. In folk medicine in West Africa, as well as in South America, decoction of the leaves has been used to treat gastrointestinal disorders. Furthermore, cashew nut occupies a central position in the diets of the human population throughout the world, and it has been proven that its consumption has a protective effect on the heart. It can have some beneficial effects with regards to body mass index, and may even help prevent some cancers in terms of its antioxidant effects. In fact, generally nuts, including cashew nuts, have been suggested as a natural source of antioxidants such as phenolics, flavonoids, tocopherols, and alkyl phenols. The leaves possess or are purported to possess anti-diabetic, anti-ulcer, and anti-inflammatory activities, some of which have been proven in clinical studies. There's some evidence that the main constituents of leaves of the cashew tree, particularly flavonoids, and I hope I pronounced these right, quercetin, apigenin, tannins, and alkaloids, exert, believe it or not, antidepressant activity through interactions with many receptors in the human body, including the adrenergic system, dopaminergic, serotonergic, and GABAergic systems. But not the cashew nuts. One study that I encountered even specifically looked for toxic side effects of the combination of the extract and standard antidepressant therapy. And in addition to this, in addition to not recording any side effects, they also found modest increases in antidepressant effects. So there is some truth to the cashew tree and antidepressants, but this mem is just inaccurate. So we're going to label this fake news. So now, after our second segment, we're going to take a break, pay some bills, and we're going to be back with our specially invited guest, Dr. Shaun Lynch, who is going to be discussing kidney diseases and a few things about kidney transplants. So if you wondered whether or not you could be a potential kidney donor or kidney recipient, stick around. We'll be back very shortly.
High blood pressure is as dangerous as an overpumped balloon. Measuring your blood pressure every day can save you from risk of high blood pressure. MicroLife fully automatic upper arm blood pressure monitor with stroke risk detection. MicroLife AFib screens for atrial fibrillation while taking your blood pressure. High blood pressure and atrial fibrillation are both considered controllable risk factors for stroke. If AFib is present during blood pressure measurement, the AFib icon is displayed flashing at the end of the triple measurement. Once 3 measurements are complete, the measurement data are shown on the display. MicroLife, a partner for people, for life.
items. Trust low-cost supermarket for the widest variety of quality products at low prices. Freshly picked fruits and vegetables, healthy products for your well-being, high-quality meat cuts, and a warm and friendly service. Low-cost supermarket, Sun and Main Road, Cunupia.
Good evening, ladies and gentlemen, and welcome back to Doctor in the House. I'm your host, Dr. Muhammad Rahman, and I am thrilled to introduce to you our specially invited guest today, Dr. Shaun Lynch, internist, nephrologist, and renal transplant physician. Shaun, welcome.
Welcome, Mario.
And thanks so much for coming on and being part of our show.
My pleasure.
So I know that this is not your first time on the show. You've been here in the past, some time ago.
Yeah, I think that was 2014 with Dr. Juman back in those days when I first came back to Trinidad. And it was a pleasure coming on the show, actually. I always look forward to it, and it's nice being here again.
Excellent. It's a pleasure to have you here. So let's let the audience get to know you a little bit. Why don't you tell us about your training experience? You can start with high school because this is Trinidad.
Well, of course, best high school in Trinidad, Presentation College, San Fernando. From there, I did my medical training at the University of the West Indies and my internal medicine training in Trinidad as well. And subsequent to that, I went to Toronto in Canada, where I did my nephrology fellowship, and I also did an additional fellowship in kidney transplant. Since then, I've been back in Trinidad 2013 now, and I've been attached to Eric Williams, doing nephrology there. And recently, I've also been placed within the renal transplant unit to sort of overrun their proceedings there.
And that is famously exciting that we're actually able to offer kidney transplants in Trinidad. Now, you were telling me before the show started that this has actually been going on in Trinidad for some time.
Yes, this has been going on for about 12 years now through the National Organ Transplant Unit, which was established, that will have been sometime in 2012, no, 2002. Am I wrong there? No, that's longer. About 12 years, so that'll be 2007. Firstly led by Dr. Leslie Roberts, who was one of our long-standing premier nephrologists. She was in charge of the program for some time. And then recently, one of our younger graduates, Dr. Jai Karan Singh, he came back for a couple of years, and he just recently left. I just recently sort of got myself in there in the last couple of weeks. To be honest with you, they have laid the path far easier for me. There was a lot of bumps within the road in the first decade that you could imagine doing such a highly specialized sort of procedure. And now that I've come in, things have been established, and it's far easier to pick up.
That's fantastic, and again, very exciting stuff. Tell me, what sorts of patients are going to require a kidney transplant?
Well, anybody who is approaching end-stage kidney disease, and we define that based on something called a GFR, we consider them eligible for a kidney transplant. So all patients should be considered for a kidney transplant. Of course, not all patients will qualify for a kidney transplant, largely based on their morbidity. Now, I wouldn't say age, because, where I trained, we would transplant an 80-year-old, for instance. But of course, the older you are, the more likely you're going to have issues with your heart or previous stroke or something that would sort of not make you eligible, or previous cancer or ongoing cancer, for a kidney transplant. But certainly, we had a saying where I train, is that every patient should be considered for a kidney transplant.
And so in Trinidad, what sorts of patients would end up requiring or end up at end-stage kidney disease? And these are usually the patients who would be on dialysis by that time, right?
So, as I keep saying, I've said this on every show that I've gone on, we have an epidemic of kidney disease in Trinidad and Tobago.
Definitely. Every
time I think it can't get worse, it does. Every day, we are seeing more and more patients who are either turning up with end-stage kidney disease for the first time sometimes, or heading there. And we are seeing quite a younger patient population heading there as well. I mean, at the end of the day, the number one cause is diabetes, diabetes, and diabetes. And we have an epidemic of diabetes being driven by obesity and poor lifestyle and poor health. So unfortunately, we are seeing rising numbers of people entering dialysis. Now, around 2013, the government at that time instituted universal dialysis, which was a tremendous change because before that, a lot of people had to pay. It's quite expensive.
And those who couldn't afford to pay
died.
And it was a horrifying experience seeing these patients. I mean,
I look back at when I was an intern sometimes, and I couldn't believe that we would sometimes send people home to die. So you could imagine the impact that had once we started and the government started to provide dialysis. What has happened now is dialysis has exploded. I don't think anybody expected it to be where it's at, but it's exploded now. And now we have to rethink, in my opinion, how we approach this in order to get those numbers down.
So let me just step back a little bit for the benefit of some of the viewers at home. What is dialysis?
So the easiest way to explain dialysis is a process where the blood is cleaned. And that's what the kidney does. It filters the blood, it takes out all the bad stuff, it takes out all the extra liquid, it takes out all the extra salt, and keeps all the good stuff in. And the process of dialysis tries to mimic that. Now, there's two types of dialysis. Most people will be familiar with the more common blood dialysis or hemodialysis, where you sit in a chair and a machine will carry your blood through a system and it will go through a filter and we give it to you back. And you can do this 3 times a week, 3.5 to 4 hours each session. But there's also a form of dialysis which is called peritoneal dialysis, where we use a natural filter within the abdomen called the peritoneum. It acts as a natural filter. And we would insert, quote unquote, clean fluid into there, and it will interact with the blood, and the bad stuff from the blood will go out into the fluid, the good stuff from the fluid will go out into the blood, and then we drain the fluid out, and that's essentially the process. The reason why I want to highlight peritoneal dialysis is there's a misconception that peritoneal dialysis is inferior to blood dialysis. Now, most people do blood dialysis largely because peritoneal dialysis requires a lot of patient self-care because they do it at home. And a lot of people feel uncomfortable doing it. But peritoneal dialysis is equally as effective as blood dialysis, and it's certainly a form of dialysis that I have tried to promote since I've been here because it's also cheaper.
It is significantly cheaper. So you mentioned there are 4 hours on a dialysis session, up to 3 times a week.
Yes.
So you're talking about 12 hours of somebody's life that they've got to now come find themselves in a dialysis center.
Yes.
Get dialyzed and then go back home and try to get money to pay for the next dialysis session.
Well, yeah, that's how it used to be, but now they don't,
now
they don't have to worry about that, which has really been, it's made my life as a nephrologist far, far easier, far more satisfying, because a lot of times these patients who couldn't afford dialysis will represent the hospital because they're ill, they're unwell. I'm sure if somebody did a costing, they would realize that paying for it was probably cheaper because these patients coming into the hospital as acute admissions all the time, that takes up dollars as well. It made my life really much better. It made patient satisfaction, patient care much better. And to be honest with you, this is not something that's universal. There are not many countries that provide universal dialysis. So we are up there, and it's something that we should actually be quite proud of.
Should everybody who has end-stage kidney disease get dialysis?
No.
These are difficult questions to discuss on TV to a non-medical audience, but I'm trying.
They're simple. And a lot of times people come and they tell me, oh, I know somebody who's been on dialysis and they died. And I said, really, I know they probably had about 200 billion people that have walked this earth that never had dialysis and they died. So the issue is not about dying, the issue is when. And we provide dialysis in patient populations to improve the quality of life and also to improve the longevity of life. But not all patient populations are the same. For instance, it's been shown with clinical trials that people who are over the age of 80, who live in nursing homes and who have to have all their care taken off. So this is not your Ken Gordon running around the savannah 80.
Right.
This is somebody who's all their self-care needs to be taken off. They're a stroke victim, probably lying in a bed. They don't do anything for themselves. That dialysis actually does not provide longevity, so it doesn't make them live longer, nor does it provide any benefit in terms of better quality of life. So there's certain patients who would come and based on their quality of life, what's going on with them, I would actually discourage dialysis. And people will ask, well, how you can do that? Well, to be honest, dialysis is not easy. You know, these older people, they have to go to a center. They spend 2 hours in traffic. They have dialysis sometimes after they feel weak, 2 hours back. Their day becomes, you know, it becomes a matter of them existing rather than living. It's a difficult conversation, but as physicians, we always have to have difficult conversations. But there are certain patient populations that I actively will sit with the family and the relatives, and I would discourage dialysis. Of course, if you're 45 years old, you know, that's not even a discussion.
Not even a discussion. I think we had commented on a mutual friend's Facebook post recently, Ravi, had posted something about palliative care in the setting of
Yes.
dialysis.
You know, so there's actually, when I train in Toronto, there's a doctor who specializes in renal palliative care and renal geriatric care because, you know, older and older people are living longer, they're developing kidney disease. There's a question of whether they should have dialysis. And certainly palliative care has been an issue that we have overlooked for a long time in Trinidad and Tobago. It's gotten better. It's gotten better in the last few years. And I think we have improved in terms of providing that end-of-life discussion and that end-of-life comfort because, you know, life is not finite. There is going to be an end. And we as physicians have to make that end as comfortable and as dignifying as possible. I think sometimes the worst thing is for these older folk to end up in a hospital bed, in a corner in the emergency room. I think in certain patient populations, we've made dying a diagnosis rather than it being just the natural end to life. So we've improved palliative care a lot. There's a palliative care unit based out of Cora, and we have a number of physicians who have actually pursued palliative care, and they've really made a tremendous improvement in the delivery in patients on dialysis as well.
Fantastic. All right, so let's take a break, pay some bills, and we'll be right back very shortly. See you again, folks.
High blood pressure is as dangerous as an overpumped balloon. Measuring your blood pressure every day can save you from risk of high blood pressure. MicroLife fully automatic upper arm blood pressure monitor with stroke risk detection. MicroLife AFib screens for atrial fibrillation while taking your blood pressure. High blood pressure and atrial fibrillation are both considered controllable risk factors for stroke. If AFib is present during blood pressure measurement, the AFib icon is displayed flashing at the end of the triple measurement. Once 3 measurements are complete, the measurement data are shown on the display. MicroLife, a partner for people, for life.
Can be viewed on the go now with the Airlink TV app for Google devices. Simply go to the Google Play Store, search for the Airlink TV app. Download the app, click on the link and fill out the form. The account activation will be emailed or texted to the user. It's safe as no credit card is needed. The first 30 days are free and you can subscribe and receive a box for your TV to stream the same content.
Shaun Limited, the Caribbean's largest manufacturers of plain and printed paper bags, leaders in plastic bags, vermicelli, split piece powder, and greaseproof paper, ideal for doubles, french fries, and sandwiches. Supplying stores nationwide. For quality products, trust Shaun Limited, 665-3336.
And welcome back, folks, and we're here, Doctor in the House on IBN, discussing kidney diseases with Dr. Shaun Lynch. So just before we went to the break for messages there, we were talking a little bit about end-stage renal disease, and before that we were talking about kidney transplant. So let me ask you a little bit about the transplant side. What persons or which persons are likely to benefit from a kidney transplant?
Nearly all patients on dialysis, as I would say. You know, the benefit of a kidney transplant, you know, if you look at any medical intervention, use of aspirin, use of statins, angioplasty, bypass surgery, it's superseded by kidney transplantation. Kidney transplantation reduces mortality by 35%.
And what does that mean exactly?
It reduces your risk of death by over a third.
By over a third?
By over a third. And that's because really...
This is compared to dialysis or compared to
dialysis.
Wow.
Compared to dialysis. And that's because dialysis is a bad thing. You know, although
what sort of complications happen with dialysis in the long term? Like somebody's been on dialysis for 15 years. What do we start to look out for?
You know, lots of stuff. You know, they have, for instance, access. If you're doing blood dialysis, your fistula, you start to have problems gaining new sites for fistula. Your veins start to close.
And these fistulas, this fistula is when the arteries and the veins meet each other. So this big swollen thing that lets them get access to the blood.
It's not necessarily big and swollen. It gets like that after
Just the ones
a while.
I've seen.
But you know, a lot of people think of it like that. But that's fine. But they get problems. So, for instance, a lot of times you get problems with access. You know, the risk of cardiovascular death, because what we're doing dialysis is unnatural. Your kidney works 24 hours a day, 7 days a week. Nice, slow, gentle process, getting rid of all that bad stuff. We do this dialysis for 4 hours where we just hit you real hard, full going for 4 hours. And then after that time, you have absolutely no kidney function for another 2 days until you come back and we hit you for 4 hours again. If you think about it, that could never replace something that's constantly working 24 hours a day. So you get something that I call the cumulative effect of dialysis over time, where they get problems with their bones, they get problems, they're just weak, they have high risk of cardiovascular death, you know, heart attacks, or what we just call sudden death. They just die. We think that's related to toxins and potassium that's built up in between the dialysis sessions. But over time, it has a number of complications on the patients.
Okay. So to avoid these complications worldwide, many years ago, they've made a move towards kidney transplant.
Yes.
In the in the kidney failure population,
Yes.
that population of people. Now, I understand that, now first of all, when the kidneys are, does somebody get both kidneys? Do they just get one? How
No,
does that
just one
work?
kidney, because once you're healthy enough, you can live a perfectly normal life with one kidney. So you can donate a kidney safely. Of course, I tell people, not because you say you want to donate a kidney mean we're going to take your kidney. You know, you have to be in pristine health, not have any chronic medical conditions. We actually check the function of the kidney.
This is to donate, to give somebody else.
In order to donate. So you know, we pick the best of the best. In a deceased donor, in other words, somebody is dead, and we are now going to harvest the kidney to give to someone on dialysis. There are different categories of donors. There's what we call a standard donor, where it's a good kidney, young patient, no comorbidities. And then there's another criteria of donation. They've actually changed the terminology now. I can't remember the terminology recently, but we used to call it what we call extended criteria. These are older kidneys. And we know that these older kidneys are not, quote unquote, as good as the younger kidneys. However, if you are 75 years, then we don't expect that we need a kidney to last you for 25 years. So the older kidneys, or these so-called extended criteria donor kidneys, we tend to give to the older patients on dialysis because it still beats being on dialysis.
Okay. So there's this live donor transplant where somebody can give you one, then there's the one that comes from the dead people, the cadaveric ones.
Yes.
Is there any difference in, I mean, is the live one better than the dead one? Are they,
Well,
which do we do in Trinidad?
We do mainly living donor transplants in Trinidad and Tobago. Most of our transplants are living donors. So you have kidney failure, you have a brother, mother, father, sister, good friend, wife, husband. Most times, wives gives to their husbands. Less so husband gives to their wives, but and they want to see you off of dialysis, so they could say, hello, I am interested in donating a kidney. In Trinidad, you have to be blood group compatible, meaning not necessarily the same, but compatible, because there are certain blood types that are compatible. You could actually do transplants across blood groups, but we don't have the facilities or the technology or the wherewithal to do it here. We did that in Toronto a lot. So we don't do those across blood group transplants. And then basically, once you present yourself, we would then see if you're eligible. We'll do a donor, what we call a donor workup. You know, most people, if you're 25 years, you're going to be eligible. I mean, there are very few people with 20 who are very young who would not be able to safely donate a kidney.
So I am aware that before it became available in Trinidad, there was well, actually, it probably still continues now, a thriving black market trade, not regionally or locally, but in the world, worldwide,
yes,
where people would go to certain countries to try to get organs transplanted. And does that still happen to you?
So it actually wasn't black market. It actually wasn't illegal. So we had a large proportion of patients who went to Pakistan. It was actually legal, and they would pay for a kidney. They would actually meet the donor, like I've spoken to some of these patients. A lot of times the donor needed the money for a dowry or something like that. Yeah,
wow.
Yeah. And it was 100% legal. Pakistan has subsequently changed the laws to forbid that. So there's no pay for kidney anywhere in the world right now except in Iran. Iran actually still allows it. Every other country, it is now illegal. That doesn't mean it doesn't happen. That doesn't mean people don't get nice, fancy ways to get around it. You know, some of the Indian guys I trained with in Toronto would tell me that they would do genetic testing sometimes on some donors because somebody will come and say, this is my aunt, this is my cousin, this is my brother, when it's somebody they've just paid. And that's how they try to get around the system of voluntary and altruistic donation.
So on that point, I'll choose the opportunity to be devil's advocate. So, and again, I'm being devil's advocate. Why is it necessary that why can't somebody just pay somebody for an organ?
So you've raised a point that I myself have raised. I tell people, for me, the best discussions when I was in training was the ethical issues around transplantation. So, you know, I mean, the idea that everything has to be altruistic, we have to do it well, is that there are people who've argued against that. Let me put it this way. There are people who've argued against that, and they've gotten my ear, to be honest with you. I think what people fear is exploitation. Yeah. You know, I've said, well, let's do it through a government agency. Why it has to be a direct transfer of money from you to me? Why can't it be, well, the government will do this thing through their agency, and may not necessarily be money, maybe a scholarship or something. I have certainly heard the arguments as to why we should not give inducements for transplantation, and to be 100% honest with you, to me, some of them are valid. A lot of people will disagree with me, but that's my take on it. Now, whether I would want to institute that in Trinidad, we're not ready for that as yet. I mean, they don't even want to introduce it in first world countries because it's fraught with controversy. A lot of times with these things with transplantation, you have to get buy-in from the population. You know, you have to get people to buy in and want to do this, and would you want to embark on something that could push certain people away? So it's controversial. It's been discussed. I've heard arguments on the other side, which in my opinion are valid, but no one has taken that step just yet.
All right, and as we're getting closer up to the time where we usually allow calls to come in, and I know there are a couple of people that are very excited to make some calls tonight. How does one go about getting a kidney transplant? So let's say there's somebody out there who has been on dialysis for a very long time, and then they start to consider, well, this renal transplant thing or kidney transplant thing sounds pretty good. Is it feasible for everyone? Do we have the capacity to do it for everyone? And how is it done?
So in my opinion, this discussion should have started even before somebody's on dialysis. You're losing kidney function, you're going to end up on dialysis. The discussion as to the best option to replace your kidney is another kidney in the form of a transplantation. So that discussion, in my opinion, should be had early in the game. But let's say you missed it, it didn't happen, you're now on dialysis. Well, the question is, do you have somebody who is willing to donate? If you have somebody who's willing to donate, we have made it a sort of open door policy within transplantation where you come with your donor. We will do the rest. If you have somebody who's interested in donating a kidney, you bring them. We will do the rest. If you don't have somebody who can donate a kidney, or let's say you had somebody and it didn't work out for whatever issues, then the other option is going on the so-called deceased donor list. Now, if we are to be honest with ourselves, we don't do a lot of deceased donor transplants for a number of reasons which I wouldn't go into. So I think the year we did the most was last year, which was about 7. So we probably have over 1,000 people on dialysis or more. So, you know, are you really going to get a deceased donor organ? Probably unlikely. But as I say, somebody wins the lotto. And I always remember I had a patient, and he had a donor, and it didn't work out. And he said, "Doc, I want to go on the deceased donor list." And I was like, well, all right, no problem. But you know, the chances of that happening is like winning the lotto. And 3 weeks later, he calls me, I swear to God, to tell me that they've called him in for a deceased donor organ. Nice. And he got it. So somebody must win the lotto. Somebody must get the organ. But the idea that we're going to be transplanting everyone, you know, we can't fool ourselves with that. And as I said, not everyone is eligible anyway for a kidney transplant. We would like to consider them, but doesn't necessarily mean they're eligible.
Okay, beautiful. All right, so now we're going to take our last break, pay some bills, and then we're going to be right back here and taking your phone calls. So the number will be across the screen. Get yourselves ready. Go and get your popcorn and drinks and get ready to take the very entertaining phone call sessions afterwards. See you very shortly.
High blood pressure is as dangerous as an overpumped balloon. Measuring your blood pressure every day can save you from risk of high blood pressure. MicroLife fully automatic upper arm blood pressure monitor with stroke risk detection. MicroLife AFib screens for atrial fibrillation while taking your blood pressure. High blood pressure and atrial fibrillation are both considered controllable risk factors for stroke. If AFib is present during blood pressure measurement, the AFib icon is displayed flashing at the end of the triple measurement. Once 3 measurements are complete, the measurement data are shown on the display. MicroLife, a partner for people, for life.
Need medical assistance? Come check us out at Ultimate Medical Clinic. We offer a wide variety of medical treatments. Why live in pain and suffer with wounds and ulcers?
Ultimate Medical Clinic also provides laser therapy for pain relief and wound healing.
We also treat arthritis, knee, neck pains, diabetic neuropathy, diabetic foot sores, psoriasis, eczema, and many more health conditions. Call us today to schedule your appointment, 665-1188, or visit us at 111A John Street, Montrose, Chaguanas.
Good evening and welcome back to another episode of Doctors in the House. And we're going to go to the very popular phone call segment we're going into it now. And while we wait on our first call, I thought I'd ask a question that I'm sure somebody is going to call and ask about very shortly. How does one become an organ donor in this country?
Okay, so at the National Organ Transplant Unit, we have these sign-up cards where you can sign up and essentially say you want to be a donor. You know, what I encourage people to do is that you should have this discussion with your relatives. Because even if you sign up as a donor, and we did this even in Toronto, we still seek the permission of your relatives. Now, if you sign up, it gives more credence that, hey, this is what he wanted to do. But in my opinion, everybody should have this discussion with their relative. You know, should something happen to me, you know, I would be willing to donate my kidneys, and you know, more than likely, in that situation, relatives always try to honor the wish of their loved ones.
You're right. It's a really important discussion to have beforehand, right? Because I suppose if somebody's relatives are being asked about it afterwards, if somebody's approaching death, it becomes something that's a very difficult question for them to start to address. Right?
Very difficult, but we have some very well-trained staff who have been very well-trained. We had a partnership with a group in Barcelona, and they went off to Barcelona. They've been trained, very good people. They approach really nicely and stuff. It's a difficult discussion. On the one hand, you have your relative there who you know, you've just probably been told is brain dead. And on the other hand, you're grieving, but you have these people coming and asking you whether you're interested in organ donation. Very difficult discussion. What I could say is that, you know, I believe in our Trinidadian people, and most times when relatives have been approached, I would say like 95% of the times, I could count on one hand, at least what I know of, people who said no. Most times they agreed to have their relative organs donated.
Gives you some pride to be a Trinidadian sometimes, eh?
Yes, it does. It does.
That's all right. I think we have our first call coming in from San Fernando. Hello, good evening. Welcome to Doctor in the House.
Hello, good evening.
Good evening,
Doctor.
Good evening.
Good evening.
I'd like to find out what are the symptoms of a diseased kidney, and is it necessarily from diabetic?
What are the symptoms of a deranged kidney or a diseased kidney?
So, very, very, very important question. So, some people will have swelling of the feet and water retention. However, in quite a number of patients, a majority of patients, kidney disease is asymptomatic. There are very little symptoms until it's far advanced. So when you have a symptomless disease, then what should happen is you should be screened. In other words, we know patients are at risk for kidney disease, and therefore we should look for it. So any patient who is diabetic, should have kidney screening. It's the official recommendation is once a year, and to be quite honest, my personal recommendation is twice a year. What does that screening entail? It entails two things. One, a blood test. And the blood test is looking at a substance called creatinine. Where most times when your creatinine is high or it's going up, it's indicative of kidney disease. But the other important test, which is oftentimes overlooked, a lot of times by primary care doctors, I cannot emphasize how much this is important, is to check your urine for blood and protein. Why is that more important? Because the first sign of kidney disease, before the creatinine starts to go up, is you would find protein in the urine. Once you have protein in the urine, something is wrong with the kidney. You should not have protein in the urine. And therefore, I tell everyone, if you go to the doctor for a cough, a headache, whatever, a dipstick test, that little strip that they put into your urine should be part of the examination. It should be just as equal as taking your blood pressure, because sometimes we pick up people with kidney disease who have advanced and bad and weird kidney disease, and they have absolutely no symptoms. But certainly people at risk, diabetics, hypertensives, patients who have had a family history of kidney disease, people who have certain autoimmune diseases like lupus that we know could lead to complications with the kidney, these people must be screened.
Okay, thanks very much for that. So we've got another call from Arima. And hello, good evening. Hello.
Good evening, Doctor.
Hi, good night.
Hi, good evening.
Yeah, thank you very much for that excellent thank you for that excellent show. Very informative.
Thank you.
You're very welcome.
Yeah, one of my question was related to the first, I just asked the question.
Okay.
What was the signs, you know, what you have to do, what steps you have to take. So, it was answered by the first, with the last question. Yeah, that was only the same question I was going to ask.
Thank you so much for calling anyway, sir, and thanks for holding the line too. You know, as he says that, so what about some actual signs of kidney disease? So if somebody, so definitely if you've got high blood pressure, if you've got diabetes, if you've got lupus, so these diseases that predispose to kidney disease, you should see a doctor.
Yes.
But the people who are not necessarily overtly diabetic or not known to be diabetic, are there any signs that could suggest that there's something wrong with the kidneys otherwise?
So as I said, some people will have some swelling and fluid retention in the legs. but most people will have no symptoms. And then once you start to get advanced kidney disease, the most common symptom is fatigue. And people put it off to a number of things. Their children, their husband, they have an increased workload at work, and they're under stress, and they ignore a lot of times the symptoms. And that's why we have people who will turn up to the emergency room, and we telling them that your kidneys are gone, you need dialysis, and they have never really had bad symptoms until that one day when they felt very unwell. They were vomiting, they may have gotten shortness of breath, something like that. So the most common is fatigue. But as I tell people, people take their car to service 3-4 times a year. They change the oil, they tune it up, change the spark plugs. Why not carry yourself to service? You're feeling well, okay, you're feeling well, but why not go to your primary care doctor, have some routine bloods done, get a general checkup, and you do that once a year just to make sure things are in shape. You do your cancer screening. So for me, I think everyone should have some interaction with a medical practitioner at least once a year, even if you have absolutely no symptoms. I'm not saying you have to go to a specialist, not at all. Going to your neighborhood primary care doctor is more than sufficient.
I mean to that. And we've got another call coming in from Shaun. Hello, good evening, and welcome to Doctor in the House.
Yes, good night, sir. My question is, I want to know whether peritoneal dialysis, whether the experience is whether it lasts, it's a long-term thing, it lasts long-term, or do the patients eventually have to transfer to hemodialysis?
Thank you very much for that question.
Okay, so that's individual. I can tell you that we have patients who've been on PD for 12, 14, 15 years. So it's not necessary that you would eventually have to transfer to hemodialysis. It sometimes happens because of complications, but it's not necessarily. I mean, honestly, I will tell you that we have quite a good peritoneal dialysis program in Eric Williams, as you know, for sure. I could speak about there. I can't speak elsewhere. And we have patients who've been doing PD well for a number of years without issue. And I think it's a very, very good option that's gotten a bad name for a lot of wrong reasons and untrue reasons. But it's not necessary that you will eventually transfer to hemodialysis.
Okay. And we've got another call from Princess Dawn. Good evening, Princess Dawn. Welcome to Doctor in the House.
Yes, good afternoon, Doctor.
Afternoon.
Good evening.
Yes, I'd like to know if strong painkillers, steroids, could contribute to kidney dysfunction.
And thank you very much. That's an excellent question. Can strong painkillers and steroids?
Right. So steroids, definitely not. In fact, a lot of these, what we call autoimmune diseases, where the body attacks the kidney, we actually use steroids to treat the kidney disease. The issue of what I'm assuming is non-steroidals. These are pain drugs, you know, that are used. Whether it affects the kidney long-term, sort of controversial. Certainly, you can get what we call acute renal failure when you use those non-steroidals. In other words, the kidney could go into a state of sleep, especially if combined with other drugs for some time, which is usually reversible. Whether long-term exposure to non-steroidals would lead to chronic kidney disease, most people will say no. There was a non-steroidal that did that, and it was eventually taken off the market. Certainly, if you have kidney disease, you should avoid non-steroidals.
Of any kind. Are there any safe ones?
No. People believe the so-called COX-2 inhibitors are quote-unquote safer. They have the exact same effect on the kidney.
How about paracetamol?
Well,
that's not an NSAID,
not an NSAID. Paracetamol is the best thing you can use for pain.
Good painkiller for kidney disease? You got kidney disease?
It's the best thing. It has no effect on the kidney. You know, the risk in the GI tract and stuff is zero. So great. Problem with paracetamol is that when you have bad arthritic pain, oftentimes don't work. That's the issue. But with regards to the use of the non-steroidals, the community is generally saying that no, doesn't really lead to chronic kidney disease. If you have chronic kidney disease, for instance, if you have diabetes, some other cause of chronic kidney disease, you should avoid it. It does have an acute effect and could lead to what we call acute renal failure or acute kidney injury, which is most times reversible.
Okay. And we've got another call from Kuva. Good evening, Kuva.
Hi, good evening.
Hi, good evening.
Hello?
Hello. Hi.
Yes, good evening, doctors. Congratulations on a very good program.
Thank you very much.
Yes. I have a question for you, doctor. What level of what value of EFCR you should really get concerned about having further examination and functioning of your kidneys?
Thank you very much.
Okay, excellent question. This could lead to a half-an-hour discussion, so I'll try to make it as brief as possible. In the United States, most of the states have, and the guy asked a question about GFR. So the GFR is like the filtering function of the kidney. And
basically, the higher you go, the better your kidneys are. The lower you go, the worse your kidneys are.
A normal GFR is about 90 to 120. Now, as you get older, you naturally lose GFR. From about the age of 25, you lose about 0.8 mils per year. So therefore, a GFR in an 80-year-old is not going to be the same as a GFR in a 25-year-old. So you have to take that into consideration as well. You also have to take into consideration the age of the person. So if an 80-year-old, for instance, has a GFR of 30, 35, I am probably less worried about him because I don't expect him to live 40 years. If a 25-year-old has the exact GFR, I'm very worried about that person because their life expectancy, remember, you need time for these things to get worse. So you have to take into consideration the patient, you have to take into consideration the GFR, and you also have to take into consideration the level of protein. Because the level of protein in the urine, the higher it is more likely that the kidney disease is going to get worse. So if, again, I have a patient who has a GFR of, let's say, 40, and they have very little protein in the urine, and they are 75 years old, I'm not too concerned about that patient. Now, what you would see in the United States, which I got into, started to talk with, is once you do a creatinine, it automatically prints out a GFR. And it automatically prints at the bottom, referral to a nephrologist is suggested if your GFR is less than 60. Now, whether I 100% agree with that, we can get into a very long discussion. That's what they would recommend. Does it mean I'm concerned if your GFR is less than 60? No, not necessarily, because that's around what we call stage 3 chronic kidney disease. And most patients with stage 3 chronic kidney disease actually don't go on to dialysis. They die of a different cause, of old age, they don't progress. So it's a number of factors, including the actual GFR, including the patient age, including the amount of protein in the urine, that would trigger my concern. And my concern being that you are going to progress. In other words, this is going to get worse, and that you're going to end up on dialysis. For instance, you can have a completely normal GFR. If you're diabetic and you have a completely normal GFR, your creatinine is 0.8, and you have 10 grams of protein in the urine, I am exceedingly concerned about you because your risk of that getting worse in a short period of time is very high. So it's a number of factors, and I'm not quite sure if I answered your question appropriately. I don't know if you're looking for an actual number, but it's not just the number. That's probably the best that I could say.
Okay, thank you for that excellent question, caller. We've got another call, this one from Valsain. Good evening, Valsain.
Good evening, and assalam.
Wa alaikum assalam.
Salam.
My question, I am 60 young. I am overweight. I am into dialysis for a horseshoe kidney.
Sorry?
So could you, for what kidney?
A horseshoe kidney?
Yes.
Yes.
Kidney. Yes. I think they corrected me and they told me it's a shaped kidney.
Yes.
What I want to know is, apart from the obvious, I have to lose weight, which is an ongoing ordeal. One, how come I'm a neurologist?
Sorry, if you could turn the volume on your TV down a little bit. I think we're getting some feedback. It's difficult to hear.
Okay, you're here. Is that now?
Yes.
How come I am in the urology clinic and so far I've had a problem with the kidney, but I want to know the precautions I must take to live long and productive with this kidney, that I don't have to get replacement kidney or something like that. Horseshoe kidney, I don't think I can get another kidney.
Okay.
You know, so what problems and precautions can I take?
Okay.
Thank you very much for that question, caller.
So a horseshoe kidney is what we call an anatomic variant. You were born with that. You were born with a kidney that is shaped like a horseshoe. And guess what? You said you're 60 years old. That kidney has lasted you well for 60 years. And to be honest with you, most horseshoe kidneys are normal kidneys. It functions normally. It may just be in a different location than where your kidneys are normally located, and it looks like a horseshoe. So most times it's absolutely nothing to worry about. Sometimes it may be associated with different issues with the anatomy in terms of the ureter and the bladder, but I suspect that you probably don't have any of those things. So to be quite honest with you, just having a horseshoe kidney is by itself not a problem. I mean, sometimes people find out they have one kidney because they went for an ultrasound, because they were having some pain somewhere, and they find out at age 50, 60, 65 that they have one kidney. And they've been living perfectly fine with that one kidney, and you can live perfectly healthy lives with just one kidney. So what I would advise you is not to be too concerned about it. What I would say is that you need to control modifiable factors like your weight, screen for diabetes, watch your blood pressure. I would be far more concerned about those issues than just having a horseshoe kidney itself.
Excellent question, caller. Thank you very much. And we've got another call from El Socorro. Good evening, El Socorro.
Yeah, good evening. Salam alaikum, Doctor. Dr. Lynch, excellent job.
Thank you.
Superbly tonight. My question is, would a person with recurrent kidney stones, for instance, uric acid type, would that person be prone to kidney disease?
And the answer to that question is 100% yes. So after a while, if these stones block up the passageway, it leads to blood pressure in the kidney. It will eventually eat away slowly at the kidney function. The question is, why are you getting recurrent kidney stones? Part of the problem is people get a kidney stone, they have a lot of pain, they go to the doctor, they go to the emergency room, they get pain relief, they get some fluids, they may get some antibiotics because they have a little infection, they may pass the stone, and everybody goes away happy and think that's it. Well, that should not actually be it, because guess what? You are at a 25% risk of having another kidney stone again within the next 5 to 10 years. So what should really happen is you should have that stone analyzed, because there are different types of stones. Most are calcium, calcium oxalate, calcium phosphate, but uric acid as well. And then there's what we do call a stone workup. In other words, there's something that is causing you to have stones, and we need to figure out what that something is. There are certain rare diseases. Sometimes a gland could be overactive in the neck called a parathyroid gland, but most times it's something within the urine itself. So we would send off the urine to test for calcium, to test for oxalate, to test for citrate, and these other things. And that's what should happen, and that seldom happens. Most times people get the stone, they do some urological procedure to get rid of it or what they have you, they're out of pain, they leave, and then they come back again in years to come with the same issue. They should have a stone workup to try and ensure that they don't present the second time with their stone. Worse yet, if you're presenting first, second, third, fourth, fifth, sixth, seventh, that is not a very good situation at all. there must be a reason why you are predisposed to those stones, and there are actions that we can take that could reduce that. You know, we were talking earlier about the herbal stuff. So for calcium stones, calcium oxalate stones, you know Trinidadians, everything with Trinidadians is rough skin lemon, it's cure everything.
Yes.
Well, that is actually 100% true when it comes to calcium-based kidney stones, calcium oxalate kidney stones. This has been scientifically proven that lemon juice reduces the incidence of these stones. We know why. It produces something called, it has something called citrate, which keeps the calcium from forming this hard stone. So that is one thing that is actually 100% medically true, proven. People who are predisposed to kidney stones, it is also 100% true that drinking a lot of fluid helps reduce it as well. And there's certain other dietary stuff and certain medications we would give depending on your stone type. But the problem is people seldom get their stone analyzed.
All right, thank you very much for that very interesting and stimulating question. And we've got another caller from Gasparillo. Good evening, Gasparillo.
Good evening, Doctor. Very, very informative program. Dr. Lynch, I have two questions for you.
Yes.
The first one is, what factors do the nephrologists consider to do either peritoneal or hemodialysis?
Yes.
And the second question is, a person 80 years old has been diagnosed with renal failure due to diabetes for the past 8 years and has been stabilized at stage 3. Once that stabilization continues, do you think there will be a need for dialysis in the future?
Okay, excellent question. So, peritoneal versus hemodialysis. The number one factor should be patient choice. That's what it should be. What do you want to do? Which fits your lifestyle better? Because remember, that once somebody has reached irreversible kidney failure and on dialysis, there are two ways you come off of dialysis. One, if you get a kidney transplant, or two, if you die. So potentially you are looking at doing this therapy for the rest of your life, and you should be comfortable with what you do. So the number one factor in determining the type of dialysis patients do should be patient choice and how they see themselves and what they think that they would prefer to do. There are other factors we take into consideration for peritoneal dialysis. So for instance, if you've had a major surgery to the abdomen, usually not appendix, usually not gallbladder, but major surgery, especially gynecologic surgery, especially a C-section and stuff. The natural filter called the peritoneum, it tends to be less effective, and a lot of times PD wouldn't work. Is it 100%? No. But I keep telling people, well, we can try and see what happens, 50-50. So certainly that is one factor I take into consideration. All the other stuff that you will hear talk to the wrong, obesity, we do PD on very large people. There's this also a myth that you have to have some perfectly spotless, clean house, you know, and you have to be so perfectly clean. That is actually not true, because once you do PD and you connect the system, it's a closed system. So once you wash your hands, no germs could come into there. And I actually went to a conference already where they were showing these workers in the dump who would do PD there. Of course, they will take their precautions and what have you. But there's a lot of myths surrounding PD that are not actually true, that may be actually told to you by some of your healthcare professionals as well. So the number one thing is really patient choice. The second question with regards to if somebody is 80 years old and has stage 3 chronic kidney disease, well, if in 8 years they haven't gotten worse, the likelihood of them getting worse in the future is small. I mean, I don't have all the information. I don't know how much the protein is, so it's difficult to say. There's actually calculators that you could use to help predict these sort of things. But if in 8 years they haven't moved and they've remained stable, the likelihood is that they'll probably remain stable.
Okay, thank you very much for that question, caller. And now we're going on to our last call for tonight, and it's coming in from Trin City. And good evening, Trin City.
Hello, good night.
Hi, good night.
I'm calling to find out what causes protein in the urine.
What causes, sorry?
Protein in the urine.
Okay. So I like to think of the kidney as like a sieve. So, you know, like you're sifting flour, and the flour will go out and all the big stuff within the flour will remain in the sieve. So that's what the kidney is supposed to do. It's supposed to keep all the big stuff like protein, and there's a particular protein called albumin. It's very big, and it's not supposed to go out in your urine. So anytime there's protein in the urine, it means there's a problem with that barrier. It's almost like if you come and create some gigantic holes within the sieve and allow the protein to go out into the urine. So it's the filter, the barrier, something we call the glomerular basement membrane, which is diseased. And it's usually diseased by the actual process, be it diabetes, high blood pressure, lupus, what have you. The problem is that protein that goes out in the urine is not just a symptom, but it actually also does damage to the kidney. So it makes things worse. So you become a relentless cycle where you spill protein, the protein makes the kidney worse, you spill more protein, it makes the kidney worse, and you just go into that relentless cycle with proteinuria and loss of kidney function.
All right, marvelous. Well, that brings us to the end of our session on this evening's presentation of Doctor in the House. Dr. Lynch, would you like to say any closing words about some of the topics that we've discussed, maybe some take-home messages from the questions and the directions that they've been going from?
Sure. So my take-home message is that we need to arrest this kidney disease pandemic we have in Trinidad. People need to get screened. I think it's fairly simple to get screened, particularly if you know you're at risk. As I said, the categories: family history, diabetes, high blood pressure, certain immune diseases like lupus and those sort of things. That's number one. Number two, I would really like to see more people come forward and donate kidneys. It is safe. It is safe. People ask, could I have a pregnancy after? Yes. It is. We don't just take your kidney because you say you want to give it. We bend over backwards to make sure that you are 100% healthy. If there's anything that just turns up not right, we would then turn down the offer of the kidney. But I would like people, to present themselves more, try and help their relatives and loved ones out, and get them off of dialysis and back to regular working life.
All right, and with those few closing words from Dr. Lynch, we'd like to bid you good evening. Thank you very much for joining us tonight. I hope you enjoyed it. I hope you were able to derive some benefit and learn some new things about kidney disease and about other things that we chat about as well. We look forward to seeing you again next time with us. And in closing, this is your host, Dr. Muhammad Rahman, saying, don't forget to be awesome. Take care. Assalamu alaikum.
High blood pressure is as dangerous as an overpumped balloon. Measuring your blood pressure every day can save you from risk of high blood pressure. MicroLife fully automatic upper arm blood pressure monitor with stroke risk detection. MicroLife AFib screens for atrial fibrillation while taking your blood pressure. High blood pressure and atrial fibrillation are both considered controllable risk factors for stroke. If AFib is present during blood pressure measurement, the AFib icon is displayed flashing at the end of the triple measurement. Once 3 measurements are complete, the measurement data are shown on the display. MicroLife, a partner for people, for life.
Need medical assistance? Come check us out at Ultimate Medical Clinic. We offer a wide variety of medical treatments. Why live in pain and suffer with wounds and ulcers?
Ultimate Medical Clinic also provides laser therapy for pain relief and wound